Hi friends, welcome to classes by Lab Doctor. In today's class, let us see how will we work up a case of hypocalcemia. So you all know that the total calcium level in the body is around 8.5 to 10.5 milligram per deciliter. That is 2.12 to 2.62 millimoles per liter. Whereas the ionized calcium, the active calcium, the free calcium is around 4.65 to 5.25 or 1.16 to 1.31 millimoles per liter. So we call hypocalcemia when the level of total calcium goes below 8.5 milligram per deciliter, or the ionized calcium is less than 4.65 milligram per deciliter. So there are many causes of hypocalcemia which we have seen. One is vitamin D deficiency. It could be because of decreased oral intake. There can be malnutrition, or the calcium is not absorbed from the small intestine. There could be an intestinal bypass. There could be gastrectomy done. There is decreased production of vitamin D. There is liver failure. There is decreased synthesis of 125 hydroxy vitamin D, which happens in case of renal failure, in case of hyperphosphatemia, malabsorption syndrome. So these can cause decreased calcium level in the serum. The other causes are alcoholism. There could be hypoparathyroidism. There could be pseudo-hypoparathyroidism, wherein the parathormone is there, but it is resistant. The parathormone action are resistant in the body. So there is resistance to this PTH action. Hypomagnesemia or hypermagnesemia both can cause hypocalcemia. Certain medications, sepsis, acute pancreatitis. What happens in acute pancreatitis? There is a lot of fatty acids which are released. They combine with the calcium in the serum and form insoluble calcium soaps, which can cause reduction in calcium. Massive transfusion with citrated blood, rhabdomyolysis, all this can cause hypocalcemia. We have also discussed about factitious hypocalcemia. So this is a condition wherein there is reduction of the total calcium level in the body, but the ionized fraction of serum calcium is normal. So whenever the serum albumin falls to less than 4 gram per deciliter, we do a correction in such cases. So that is called as factitious hypocalcemia. So how do we do the correction? Corrected calcium is equal to whatever is the measured calcium plus 0.8 into 4 minus albumin. So suppose if the serum calcium we got is 7.5, that is hypocalcemia as per definition, less than 8.5. The albumin of the patient is 2 gram per deciliter. So what is the corrected calcium here? 7.5 plus 0.8 into 4 minus 2. So that is 7.5 plus 1.6. That is 9.1, which is very much within the range for total calcium. So whenever there is hypocalcemia, we will have to do the adjustment. We will have to get the serum adjusted calcium. And suppose when we do the serum adjusted calcium, that comes below 2.2 millimoles, or you did a ionized calcium and that comes below 1.2 millimoles, then it is called as hypocalcemia. So whenever you get such cases of hypocalcemia, you confirm hypocalcemia and undertake a clinical assessment of risk factor, whether patient is on any kind of a medication, patient is having chronic kidney disease, whether the patient has undergone any kind of a surgery where the parathyroid has been removed, and accordingly we will have to proceed. So we will have to do certain other tests also. So the first line of testing would be, we would have to do a parathormone, we would have to do the phosphate, we would have to do the magnesium, the creatinine, the estimated GFR. The second line of testing would be the vitamin D, the amylase, etc. So based on all these parameters, we will approach a case of hypocalcemia. When we evaluated this patient And if we get increased parathermone and increased phosphate, so what could be the causes of this? One could be that patient is having pseudo hypoparathyroidism. That means there is increased parathermone, but body is resistant to that parathermone. So though the parathermone is high, calcium is low. In massive tumor lysis, what happens in massive tumor lysis? The cells are broken. So the phosphates which is there inside, it is rich inside, that is coming outside. So the phosphate is high in massive tumor lysis. In chronic kidney disease, what happens? The absorption of calcium is deranged. So when calcium decreases, the phosphate will increase. So all such cases can lead to hypocalcemia associated with increased PTH and high phosphate. So hyperparathyroidism. In hyperparathyroidism, what happens when the parathyroid gland produces too much of PTH? It could be because of an adenoma, etc. That will lead to increased PTH and increased phosphate level. Now, like in hyperphosphatemia, whenever the phosphate level in the bloods are too high, like it can be caused by impaired renal phosphorus clearing, like in case of chronic kidney disease, etc. And this increased PTH and phosphate can cause lot many problems and health issues to us. Like it could be bone issues, it could be cardiovascular issues. It can also cause mineralization of vascular smooth muscles. So I've told you in tumor lysis syndrome. In tumor lysis syndrome, what happens? There is hyperphosphatemia. Hyperphosphatemia also causes precipitation of the calcium. It will combine with the calcium and forms calcium phosphate. So the level of calcium is also going to decrease. So when the tumor is lysed, the rich intracellular phosphate is going to come out, and this phosphate which is rich intracellularly, when it comes out, there is increased high phosphate level. This phosphate is going to bind with the calcium. It forms calcium phosphate, and low level of calcium can occur in the blood. That was about the increased PTH, increased phosphate in case of chronic kidney disease, pseudo hypoparathyroidism, or massive tumor lysis. So sometimes you might get high PTH and low phosphate. So you have a patient whose calcium is low, so his PTH is high, but he is having low phosphate. This happens in case of vitamin D deficiency. So vitamin D deficiency causes increased level of parathormones. So this parathormone is released to increase the level of calcium. So when calcium is raised, the phosphate level is going to be low. So in certain cases of hypocalcemia, like wherein you will see that there is hypocalcemia, patient's parathormone is more and his phosphate is less. That is because of vitamin D. So vitamin D, it will sense that calcium is low, it will tell the PTH to increase its secretion. So PTH gets more, but what happens to the phosphate? Calcium is also now trying to increase and the phosphate is going to go down. Sometimes what happens? You will get a case wherein the patient has low calcium, his parathormone is low and his phosphate is high. Now where you will get low parathormone? Whenever there is damage to the parathyroid glands. So suppose if there was a thyroid surgery, or there is a radiation, or there is a cancer, or there is an autoimmune disease, or certain genetic disorders, they can cause damage to the parathyroid hormone. So whenever there is low parathyroid hormone, we expect that there is low calcium. And whenever there is low calcium, the phosphate can increase. So whenever there is hypocalcemia, always find out whether it is actual hypocalcemia or factitious hypocalcemia. Do the correction. You will get a corrected total calcium level. Otherwise, estimate the ionized calcium. So when you estimated this, assess for other causes of calcium loss. See if the patient was given any citrated blood transfusion, patient is having acute pancreatitis, patient is having sepsis, etc. Assess the vitamin D status of the patient. Suppose if the vitamin D deficiency is there, if the vitamin D is less than 20 nanogram per ml, you know that because of low vitamin D, there is low calcium. Now, low vitamin D can happen because of low decreased intake of vitamin D, less of sun exposure, or there is some issue with the gut, there is malabsorption. So then you have to give that patient vitamin D. You assess the vitamin D of the patient and you found that patient is having increased vitamin D, but the patient is having hypocalcemia. So when the vitamin D level is normal or high and hypocalcemia is there, we should always think for hypoparathyroidism. Is there anything wrong with the parathyroid gland? Is it causing low calcium? I've told you assess the PTH level. So if you get an increased PTH, you know that it can be because of uh, malabsorption or vitamin D deficiency or hypophosphatemia. That is secondary hyperparathyroidism. So because there was malabsorption, there was low calcium, there was low vitamin D. This has stimulated the parathyroid hormone and because of which it was elevated. Suppose if you are getting a case wherein the patient is having low calcium and his parathyroid hormone is also low, think of any surgical procedures which are done to the parathyroid, parathyroidectomy, neck surgery, etc. You will also have to evaluate the serum magnesium. Suppose you got a patient, his calcium is less and his magnesium is also low. So if you are having calcium low, magnesium low, think whether patient is losing both, whether he is having vomiting, loose motions, diarrhea, malabsorption, whether he is wasting it in the kidney, whether he is having kidney disease, whether he is malnourished, etc. Suppose you get a patient who is having low calcium but normal magnesium. Again, think whether it is due to defect in the parathormone, whether parathyroid was removed. That is why now the patient is having less of a calcium and his magnesium is normal. So this is how we will evaluate a case of hypocalcemia. So it is just not the calcium, lessened calcium which would help us. There are various other first and second line of testing which we have to do, including serum magnesium, the PTH levels, the vitamin D level, and the other history taking, etc., which all together will help us to find out what could be the cause of hypocalcemia. So we will have to correlate with all these and then find out the cause of hypocalcemia. Whenever there is hypocalcemia, when the level of calcium is less than 8.5, see how severe is the hypocalcemia. If the calcium level is less, that is if it is it is less than 8.5 but more than 7.5, you can give elemental calcium. You can give 500 mg to 1 gram of calcium per orally, and you will have to monitor the level of calcium weekly. Suppose you get a calcium which is less than 7.5, we might have to give IV calcium supplement. The goal is to maintain the calcium levels from 8.5 to 10.2 milligram per deciliter. That was about how we approach a case of hypocalcemia. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.